The following podcast is part of a certified educational activity titled Adapting Managed Care Strategies in the Era of Precision Medicine for Hypertrophic Cardiomyopathy. Access the entire activity and complete the post-test at peerview.com/DMR860. Downloadable slides and practice aids are also available.
Good afternoon, everybody. My name is Andrew Williford. I'm an assistant professor at UC San Diego. My practice is in heart failure as well as hypertrophic cardiomyopathy, where I run an outpatient titration clinic for heart failure, in addition to a lot of our medications in particular that we'll talk about, mavacamten today, for our patients with obstructive hypertrophic cardiomyopathy. So I'm really excited to be up here today with Dr. Milind Desai. Kind of a fanboy of Dr. Desai, so I'm even more happy to be here. But we're really excited to be talking about the really adapting managed care strategies in the era of precision medicine for hypertrophic cardiomyopathy. And so our goals today are to recognize the multifaceted burdens of HCM, or hypertrophic cardiomyopathy, and the consequences at the individual and societal levels. In addition, we'll better grasp the management guidelines and treatment data that inform HCM decision-making in a managed care environment. We'll also apply relevant considerations, including pharmacoeconomics, equitable access to care, and patient quality of life in updating HCM management protocols. All right, so let's go on and get on into it. So hypertrophic cardiomyopathy, or HCM for short, you can kind of think of it as left ventricular wall thickness that's not explained by abnormal loading conditions. Diagnostic-wise, we can see that in the LV wall, thickness is typically greater than or equal to 15 millimeters, or greater than or equal to 13 millimeters in individuals with a family history of HCM, or in conjunction with a positive genetic test that's diagnostic for HCM. So with regards to those mutations, what we know is that the primary, most common mutations include those in myosin heavy chain, which is MYH7, in addition to myosin binding protein C, or MYBPC3. Symptoms generally include dyspnea, fatigue, chest pain, even while you're eating, palpitations, and syncope. Also, it's associated with various complications, including risk for arrhythmias, heart failure, and sudden cardiac death as well. So HCM affects all sexes, all races, and all ages, and really just all places throughout the world. So what we know, just kind of from observations, with regards to sex, female patients are typically diagnosed a little bit later than male patients. Black patients have more heart failure symptoms, are often less referred for symptomatic management, so a bit of a disparity in care right there. With regards to age, the median age at diagnosis is 46. So you can think 50% older than 46 are diagnosed, and then 50% lower are under 46. So as I mentioned a little bit, there are disparities in treatment, and those kind of relate to in-hospital mortality and are kind of different based off of sex, race, insurance status, kind of rural location where you live, and just kind of the hospital in general as well. So with regards to prevalence of hypertrophic cardiomyopathy, it's estimated about 1 in 500 individuals, maybe even as high as 1 in 200 individuals have hypertrophic cardiomyopathy. You can think of HCM as not really rare. It's actually relatively common, but actually quite underdiagnosed. So you can think at bare minimum, we have potentially about maybe 700,000 Americans in the United States living with hypertrophic cardiomyopathy. So with regards to the pathology in the heart for hypertrophic cardiomyopathy, you can easily divvy it up into obstructive HCM, or OHCM, versus non-obstructive HCM, which is NHCM. So if we kind of go left to right here on the slides, we have our normal heart here. We could have non-obstructive hypertrophic cardiomyopathy, where we get some septal thickening here, but there's no obstruction to forward blood flow. With regards to obstructive HCM, or OHCM, we actually get obstruction to forward blood flow from the left ventricle out through the aortic valve and through the aorta. So what we can see is on echocardiography, you can actually measure a pressure gradient through the left ventricular outflow tract, which is this area right here, again, just a little bit below the aortic valve. In obstructive HCM, those individuals will have a gradient greater than or equal to 30 millimeters of mercury. You could also even look at other different kind of pathologies of HCM, which could be mid-cavitary in nature. There could also be a possible obstruction there just in the mid-cavitary region of the left ventricle. We could also even have apical hypertrophy, which is most of the hypertrophy towards the bottom of the apex of the heart in the left ventricle, where we have a decreased chamber size, but really no obstruction that you can measure as a pressure gradient on echocardiography. So as I highlighted briefly a little bit, symptoms of obstructive HCM are quite variable, and they really fluctuate daily from whatever the patient is going through, whether it's different activities, temperature outside, meal size, alcohol, many other factors can actually affect symptoms, whether or not they have them or they don't have them. And what we know is that a decent amount of patients complain of shortness of breath, exercise intolerance, lightheadedness, dizziness, and fainting, arrhythmias, palpitations, and chest pain, just like I mentioned earlier. So with regards to treatment, we'll get into a bit more in depth in a moment, but in general, we have various kind of treatment modalities that we can utilize to treat the different complications of hypertrophic cardiomyopathy, such as ICDs to help with preventing sudden cardiac death. We have GDMT available for heart failure with reduced ejection fraction for individuals who actually go off into that realm of HFrEF, even though they have HCM. And then various antiarrhythmics, anticoagulation, ablation strategies are available for AFib and stroke. The one that we'll be talking mostly about today all relates to symptomatic left ventricular outflow tract obstruction. The medications we have are actually quite dated. It's AV nodal blockers like beta blockers, calcium channel blockers, in particular non-dihydropyridine calcium channel blockers like verapamil and diltiazem. We can even also use disopyramide, which is a class 1A antiarrhythmic, sodium channel blocker, actually has quite an amount of negative inotropic effect, which is why it's utilized in patients with hypertrophic cardiomyopathy. There's also different kind of septal reduction therapies that are available to us. Those include septal myectomy, which we'll talk about, and alcohol septal ablation. Septal myectomy is actually a surgical procedure where they actually slice out, to put it simply, a portion of that hypertrophied area within the heart to allow for better forward blood flow. So one thing to think about with regards to these kind of dated medications, beta blockers, calcium channel blockers, and disopyramide, is that these conventional medicines are all based off of really kind of non-robust, mostly retrospective or small prospective randomized or prospective trials that are not randomized or controlled. They're not disease modifying either. They're there to just essentially decrease contractility of the heart to try to provide some symptom relief for our patients. So that in itself, with regards to medicines that patients can take, leaves a kind of area of care that needs to be tackled with regards to something that needs to be disease modifying, something that will actually have robust data behind it in a placebo-controlled trial. That is where cardiac myosin inhibitors, which are new to the game of hypertrophic cardiomyopathy, come in, which is down here, cardiac myosin inhibitors, which we'll talk about extensively for the rest of this talk too. So before we get into the next section, let's introduce our hypothetical patient. Her name's Angelica. She is a 59-year-old female with a history of obstructive HCM. Diagnosed 3 years ago, she has functional class 3 symptoms, so symptoms with kind of minimal exertion, those kind of situations. She has an ejection fraction, that LVEF, of 65%. Her left ventricular outflow tract gradient is greater than 80, so remember that cutoff was 30. And she has mitral valve regurgitation that we can see on echocardiography as well. She experiences shortness of breath, chest pain, functional limitations, like she can't tie her shoes, she can't be on her feet for more than 3 hours, pretty limiting with regards to her quality of life and her ability to live. Now, despite her HCM diagnosis, she does not qualify for disability, and so she fears about her health challenges and the consequences they will have on her job. She also, with regards to her annual visits to the HCM center that's closest to her, require her to take 2 days off in order to go there to get follow-up, and it's costing her and her partner a lot of out-of-pocket travel costs. All right, so I'll hand it off to Dr. Desai.
So thanks a lot. Thank you very much for coming, and thank you for the invitation. Great job, Andrew. I'm Milind Desai from the Cleveland Clinic. Where are we as it relates to current guidelines and recommendations vis-a-vis managing these patients? So, as was mentioned, Angelica has a lot of issues, and she's currently treated with losartan, 50 milligrams a day, amlodipine, and long-acting metoprolol. She was treated with disopyramide, but had intolerable side effects. So how do these pills align with standard of care as it relates to HCM? And are these therapies serving her well? So what do the guidelines say? 2020 American guidelines, ACCA guidelines state that let's focus on the right, the obstructive HCM. Your first-line therapy should be beta blockers, non-dihydropyridine calcium channel blockers like diltiazem or verapamil. Avoid high-dose diuretics. Avoid vasodilators. Add disopyramide if these things don't work. And if your back is against the wall, then you have septal reduction therapy like myectomy or alcohol septal ablation. We won't focus much on the other group. If you have non-obstructive, essentially there's no randomized trial data. And in advanced cases, before you get on the transplant wagon, you may consider in some cases a highly specialized procedure where we do a myectomy of the apex. So fundamentally, we have these therapies that we talk about, the beta blockers, diltiazem, verapamil, and avoidance, lifestyle modifications is an important part of the management plan. So if you look at this patient was on losartan and amlodipine, two things that can make the symptoms worse. 2023 ESC guidelines, the last iteration of ESC guidelines, I believe from 2014, looked very much like the American guidelines that we talked about, but now there's a new kid in town. So if you are symptomatic, start with beta blockers or verapamil or diltiazem, and if you remain symptomatic, then for the first time, there's introduction of mavacamten as a class 2A recommendation. The important thing here is the level of evidence, as was mentioned before, for all the other class of drugs is weaker based on observational and retrospective data. For the first time in HCM guidelines, now we have a class of drug, mavacamten, which gets level of evidence A, which means more than one randomized controlled trial data. And if that doesn't work, then move to septal reduction therapy. Now, septal reduction therapy is awesome. It has excellent outcomes if you go to the right center. The problem in this country and the rest of the world is there ain't enough experienced high-volume centers. The guidelines recommend that your mortality needs to be less than 1%, your gradient needs to be less than 10, you should be able to return to activity, etc. All the good things, all aspirational. The problem is, if you go to a low-volume center, your risk of mortality could be 1 in 6. If you go to a high-volume center like the Cleveland Clinic or Mayo Clinic or some of the other high-volume centers, your mortality rate is close to 0%. Okay? So this is a widespread, and if your median age is 46, can you imagine telling a 46-year-old patient, you have a 1 in 6 chance of dying if you go to a low-volume center? So this is all fine and dandy. What is the real data? This is our paper that we published last year, where clearly there was an inverse association between the volume of myectomies done or alcohol septal ablation done and your outcomes. Higher the volume, better the outcomes. Having said that, what is the unfortunate reality? In this data set, this was Medicare data set, 70% patients underwent septal reduction therapy at low volume centers. So talk is cheap. We can write all the guidelines we want, but this is the reality. Okay? So this is where we have unmet needs and we can do better. Family history affects Angelica. Coming back to Angelica and her treatment preferences, she had a cousin who underwent SRT for his obstructive HCM. during the perioperative period had a stroke with significant ramifications. So Angelica is rightfully freaked out about that and wants to avoid an invasive procedure to the best of her abilities. So again, to reiterate, before cardiac myosin inhibitors came to the market, what were the studies? What was the lay of the land? Pretty much, it's been around. Beta blockers, DISO, calcium channel blocker, everything has been around, but weaker evidence. 2022, when FDA approved mavacamten, that's when we started having level of evidence A. Okay, so now the game is changing for the better. So it was brought up that she might be a candidate for treatment with cardiac myosin inhibitor, but she wants to know more about what this new kid on the block is all about, right? So what are cardiac myosin inhibitors? These are small molecule allosteric cardiac myosin inhibitors. Mavacamten is the first in class. It is approved by the FDA for symptomatic NYHA class 2-3 obstructive HCM symptoms to help improve their functional capacity. It has a half-life between 6 and 9 days. Aficamten is second in line. It is currently an investigational product going through the phase 3 testing with a half-life of 2.8 days. How do they work? Mavacamten reduces myosin head availability. So the action is at the sarcomere level where there's a lot of actin myosin cross bridges. So the heart is in a state of hypercontractility. These class of drugs relax that significant hypercontractility, stabilize the heart, make the heart use energy efficiently. Aficamten slows phosphate release from the myosin, stabilizes these actin myosin conformations. Bottom line is both of them are cardiac myosin inhibitors. They take the edge off of hypercontractility of these overworking sarcomeres and make them work more efficiently in terms of energy utilization. Okay? These are precision drugs developed specifically for the pathophysiology that underlies HCM, supported by randomized controlled trial data. All right, so where is the data? Phase 3 randomized controlled trial data for mavacamten. EXPLORER-HCM was the first trial conducted in about 251 patients with obstructive HCM. 73% of these patients were in NYHA2, the rest were in NYHA3. Basically, this tested mavacamten versus placebo, and subsequently, every patient was offered long-term extension to be on mavacamten. Bottom line is, all primary endpoints were in favor of mavacamten in terms of improving NYHA class, functional capacity, etc. Kansas City cardiomyopathy score, biomarkers in addition to the LV outflow tract gradients. And safety, and it was deemed safe and tolerable. This is the data that was recently published in February 2024. Again, long-term extension showing very similar to earlier reported data. So what are the results here? As long as you stay on mavacamten, your functional class is significantly improved. Significant proportion of patients improved from baseline as far as their NYHA class is concerned without significant worsening of their ejection fraction. Remember, these are cardiac myosin inhibitors, so we have to worry about that, or at least we have to make sure that we are not overdoing it. What else did it show? Resting and Valsalva outflow tract gradients, that this is a key marker that we monitor in these patients. They were brought down to normal and remain normal throughout the extent of the long-term duration, up to 84 weeks and beyond. So these are highly effective drugs. If you stay on it, there's no breakthrough. People will have symptom relief as well as gradient reduction. Additionally, every patient also had Kansas City quality of life ascertainment using KCCQ score. And what we found, these are various different therapies. Everybody here has a pharmacy background, so all kinds of heart failure medications. The EXPLORER-HCM showed the mean KCCQ score improved by 9.1, which is far better than pretty much any other heart failure medication out there. And it is reaching, it is somewhere in between device therapies and clearly heart failure medication. So this is significantly improving patients' quality of life. We were not satisfied fully, so we said, okay, these are NYHA 2-3 patients, but HCM patients, what happens? You know, those patients who are at the end of the road and need septal reduction therapy. Okay, so this is another phase 3 study that was conducted, the VALOR-HCM study, where the question was asked, can we use mavacamten as an alternative to reduce the need for septal reduction therapy in severely obstructive HCM patients? Full disclosure, I was the principal investigator of this trial. Okay, so 16 weeks, this was placebo versus mavacamten, and then at 16 weeks, all the placebo patients crossed over to mavacamten. And basically, what we did was real-life measurements where we measured their gradients, their symptom improvement, as well as their Kansas City score, et cetera. Okay? And there was a long-term arm extending up to 56 weeks. What were the results? Every patient was referred for septal reduction therapy. So every patient at baseline met criteria for SRT. Okay? At 16 weeks, patients in the original mavacamten group, 82% no longer met criteria for SRT. A pill reduces the need for open heart surgery or an invasive procedure in 8 out of 10 patients. The effect persisted for 56 weeks, where 9 out of 10 patients continued to not need septal reduction therapy. In the placebo group, 77% at 16 weeks were still candidates for surgery, but they started behaving, once they crossed over to mavacamten, they started behaving similar to original mavacamten group. Again, you look at the gradients. The blue is mavacamten group from the get-go. Gradient is obliterated and stays obliterated. In the placebo group, up to week 16, the gradient still is bad, and it then gets better and starts behaving like the mavacamten group, both resting gradient and as well as Valsalva gradient. It was deemed to be safe. There were 12 patients who needed temporary or permanent interruption because of drop in ejection fraction less than 50%. Why do we use 50% in HCM? Because these are hypercontractile patients, so the guidelines recommend a cutoff of 50% as normal versus abnormal, or as concerning compared to other causes of heart failure where the cutoff is 35%. Bottom line is not significant worsening of ejection fraction over 56 weeks. And majority of the patients, 75% patients who we had to stop the drug or interrupt the drug because of EF drop, were able to resume mavacamten after a temporary interruption. It also significantly improved NYHA class. 93% had at least one class improvement. Almost half had a 2-class improvement. Third trial. Now, all this was in North American and European population. This is EXPLORER-HCM was conducted in China, where also a lower dose was utilized as a starting point, not just 5 milligram dose, and similar findings as in terms of gradient improvement as well as NYHA functional class improvement was seen. And here, there were no temporary or permanent interruptions of the drug. There's the second in-class drug, which is the aficamten, has recently completed SEQUOIA-HCM trial. It is, again, a phase 3 clinical design, similar aficamten plus standard of care versus placebo standard of care, and up to week 28. And basically, for full disclosure, these results have not yet been published in peer-reviewed literature, but if you Google the company has chosen to release top-line results, which have shown, similar to the EXPLORER trial, a significant improvement in peak VO2, secondary outcomes, similar improvement in KCCQ, NYHA class, as well as in a small subgroup. Remember, this was not designed to answer the question about SRT. In a small subgroup, they also showed a change in guideline eligibility for SRT. So similar data. In this case, the proportion of people on beta blockers was much lower than the EXPLORER trial. So where do CMIs fit in the management of HCM? We still got to do the right thing, treat the comorbidities, treat the symptoms, avoid things that make outflow tract obstruction worse. Then you proceed to beta blocker, and if it doesn't work, then based on EXPLORER data, you can move to mavacamten. Or you can say, I'm going to send them to surgery. But there may be patients who say, I don't want to go to surgery. I don't have access to a good high-volume surgical center. Then based on the VALOR data, we can consider using mavacamten as an alternative to surgery. If it doesn't work, then you can still consider sending them to an appropriate SRT center. So the guideline paradigm, the paradigm of how we are going to approach this is rapidly evolving. So what's next? So, 60 years of this diagnosis, no randomized controlled trials. Now, every week there's a new randomized controlled trial or a new company popping up. So there are these MAVA, EXPLORER, MAVA-LTE, VALOR we talked about. ODYSSEY is a phase 3 trial testing mavacamten versus placebo in non-obstructive HCM. The randomization is complete. I know that because I'm also the global study PI and chair of that. So that's another full disclosure. SEQUOIA, we should hear about the results soon. MAPLE is testing AFI versus metoprolol. It is ongoing, and ACACIA was just initiated, which is testing aficamten versus placebo in non-obstructive HCM. So I will hand over to Andrew to carry on. This is pharmacy stuff that, too complicated for a simple cardiologist like me.
So as Dr. Desai nicely illuminated, that there is a risk or there is some reduction in that ejection fraction as shown in the EXPLORER trials, the VALOR trial. So there is some residual risk for left ventricular systolic dysfunction that we can define as having an EF less than 50%. So with that in mind, in the United States, we have a risk evaluation mitigation strategies program to help monitor and prevent that from happening. So what's required in that program is to get scheduled echocardiograms to monitor for left ventricular ejection fraction. Kind of the basic rules are, don't initiate mavacamten if your baseline echo is less than 55%, and interrupt therapy if your ejection fraction dips below 50% while on mavacamten. Now, one thing we haven't mentioned as well is that mavacamten is a 2C19 and 3A4 substrate, so there are specific DDIs that you have to keep in mind that are actually detailed all over the place in the package insert. So when it comes to weak 2C19 inhibitors, moderate 3A4 inhibitors, there is a dose reduction that can be made to mavacamten, but there are also other contraindications that you have to keep in mind for stronger degree of these inhibitors and inducers. So you always have to talk about kind of over-the-counter medications, new prescription medications with your patient to ensure that they're getting a good regimen of medicine that doesn't interact with their mavacamten if they're on this therapy. So you can kind of see just even from this one slide, it's a bit complex in terms of management that requires a lot of buy-in from all the stakeholders that you have in your clinic space. Your physician, Dr. Desai, your pharmacists, your nurses, and really even the patient. The patient has to buy into this to say, I will show up to my echocardiograms so that I can get this therapy. We can't give you the therapy if you don't get your echoes, and just communicate with us with regards to any new medicines that you may be starting. And so everybody needs to be trained with regards to our physicians, pharmacists, pharmacies that are dispensing, and the patient. So here's a little view into what that echocardiogram schedule looks like. You get a baseline echo, and then once you start the therapy, if you are actually a qualifying patient, your next echoes are all tied to when you start taking the medicine. So you have to get a week 4 echo, a week 8 echo, and a week 12 echo, at which we monitor for the ejection fraction and changes in that Valsalva, or provoked left ventricular outflow tract gradient. You can make a dose adjustment once you get to week 12, at which you have to get follow-up echoes at another 4 weeks later. But once you get to a maintenance dose where your left ventricular outflow tract gradient is less than about 30, then you can go to every 3 months thereafter to just get maintenance echoes to look at your ejection fraction, make sure your LVOT is still looking good as well. So despite this kind of pretty rigorous requirement from patients, there is still significant quality of life benefits to patients that really can help with regards to making this worthwhile. So as I kind of highlighted a little bit earlier, there are specific drug interactions to look out for that I talked about. On the contraindicated side, you want to avoid moderate to strong 2C19 inhibitors or inducers, and then strong 3A4 inhibitors or moderate to strong 3A4 inducers. It's a mouthful. Whenever I'm training my colleagues on all of this, I always tell them, look it up. Be sure you look it up every time. Don't pretend like you know everything, because we don't. It's impossible to memorize absolutely everything, so use our resources in order to make sure we're doing the right thing. So good examples are protease inhibitors. Even omeprazole, cimetidine, fluconazole, and amiodarone require some amount of a dose adjustment if patients are starting the therapy. Other ways I try to think about it myself when I'm managing my own patients on mavacamten is to ask myself, what alternative therapy can I use or can be used that doesn't interact with mavacamten? Also, there's some clinical experience that suggests that there's probable interactions with alcohol and marijuana, so it's a good idea to get a good social history when starting this medicine from your patient.
Angelica wants to try a CMI. After discussion with members of our healthcare team, including both of us, Angelica is now indeed deemed to be a candidate for mavacamten. REMS enrollment issues, prior authorization is sought. What next? So, patients, obviously this requires a front-ended conversation where we talk about all the interactions. We talk about the fundamental thing is the ejection fraction issue and the need that this is a binding contract between us and the patient. If you don't show up for your echo, you ain't getting no drugs. Simple. So that we have to be on the same page. Bottom line is they have to inform us if there are any new changes. If a PCP wants to start something funky, they need to let us know. Before they start any over-the-counter medications, they need to let us know. And all of us have to adhere to the REMS requirement. Basically, there is concerns about fetal risk and contraception need during and for 4 months after mavacamten use. There are nurse navigator programs. As we have learned to live in this brave new world, we have adapted. We are fairly creative, so we have gotten better, but there are websites available that can help guide the patients through the right process, patients as well as providers. So we will talk a little bit about the real world experience. What have we learned? I think humans are a very adaptive species, so I will talk about this real-world experience at a tertiary care center because this is our data that is published, and I was the first author. So the first 150 patients that we started on mavacamten, we have now a lot more than that. These were consecutive adults, persistently symptomatic, and after discussion were started on mavacamten. 65 years of age, 83% on beta blockers. So similar to what trial experience and our real life is. 61% in NYHA class 3 at entry. So per the REMS protocol, everybody was started on 5 milligrams with dose titration similar to VALOR study based on symptoms, LVOT gradient, and EF assessment. Basically, what we saw, the difference compared to the trials, I wanted to highlight this picture, this table here. In the VALOR study, for instance, about 3% patients were on 2.5 milligrams of dose. Here, much higher. There were much higher proportion of patients, I believe about 19% or so, in the VALOR trial who were on the maximum dose of 15 milligrams. Here, we were a little bit more conservative. In real practice, we tend to be a little bit more conservative. What did we see? 61% at baseline were in NYHA class 3, 4 weeks, 28%, and at 12 weeks, 8%. 46% reported at least one NYHA improvement, 18% at least additional 2 NYHA improvement, and 27% reported no change in symptoms. But the folks who did not report a change in symptoms still had a significant improvement in their LVOT gradient, suggesting what? That their symptoms are probably coming from something else. So EF, not significant difference. Changes in the gradients, similar to the trials, major improvement. Safety, only 2% patients required temporary interruption because of EF less than 50%. Only 2%. I think probably because we are a little bit more conservative in our titration schemes. Low rate of interruptions suggests that maybe we are overdoing it with the frequency of echoes. So far, none of these patients have undergone septal reduction therapy or developed EF less than 30% or developed heart failure requiring admissions. And 22% and increasing, we were able to reduce or get rid of the background medical therapies. Many of them were giving them side effects. Okay? There are differences. So titration in the trials happened at 8 weeks. Here, we waited for up to 12 weeks for up titration or down titration. So there were some subtle differences, but this is the real world where the rubber meets the road. Out-of-pocket costs. After REMS enrollment, the DDI and safety assessment, everything was discussed. 54% were on commercial insurance, 21% were commercial plus Medicare, Medicare alone 21%. So this was a myth when we were starting that Medicare is gonna be impossible to navigate. 3% Medicaid, including a patient in New York Medicaid. Try getting that approved sitting in Ohio. So mean copay here was $16, and 69% patients had a copay of 0, 25% had a monthly copay of 10. So this obviously requires a fair bit of logistic operationalization and challenges, which we navigated early on, but now this has become a very seamless process. So we have our facilities in Ohio and Florida, and our patients have come from all over the country, including Alaska and New Mexico and everywhere. 35% patients in our practice had local follow-up echoes that were transmitted to us. So it's not that they have to come to Cleveland for this. And 9 different specialty pharmacies dispense this drug. Everybody that needed or we thought needed to be on mavacamten got access to mavacamten. There are, before I go this to Andrew, there's multiple other emerging such evidence. So recently a paper was published out of UPenn with very similar experience. There's a small series of about 23 patients from New Jersey with very similar experience. And there's another paper being in press or being submitted from Stanford. So bottom line is we are collecting a lot of body of evidence suggesting real-world efficacy and safety of mavacamten. This is too complicated for me as a table, so it goes to Andrew.
So this is, as Dr. Desai is talking about too, is with regards to all this real-world evidence, each of those sites is utilizing some form of a designated workflow. And this diagram here is actually the exact workflow I use in my clinic for getting mavacamten to our patients. It's a multidisciplinary workflow, utilizes our pharmacists like myself, our cardiologists, our nurses, and our echo coordinators. But as you can kind of see, to elucidate what this requirement is, oh, there we go. So we usually, what we go through is, and this is kind of a template you can think of. It could be almost a plug and play with regards to personnel. It doesn't have to be a pharmacist, but at UCSD, we're just lucky enough where we have somebody in clinic at all times to help manage this. And so we have our cardiologists assess the patient for initiation. They then refer the patient over to the pharmacist where we assess drug interactions, need for contraception. And then we counsel the patient. We discuss everything that we talked about earlier with regards to having some skin in the game. You got to show up to get this medication in order and get your echocardiogram done accordingly. We then write initiation notes, which is important about the kind of prior authorization purpose. That's what we submit in order to actually help with the seamless transition to get the medication to the patient. We then have either the pharmacist or the nurse just kind of proactively enroll patients into patient assistance to see if we can help with any cost reduction measures. And then as we get all that done, prior authorization submitted, we check for approval, and then we discuss a start date with the patient. As I kind of illuminated a little bit earlier, the echocardiograms week 4, 8, 12 onward, they're all tied to when the patient starts taking that medication. So once we get that start date set, we then order all of our echoes. We kind of work with our nurses, our echo coordinators to get all of that set. We do the first 3 echoes right off the bat in order to help with just scheduling purposes for our patients. And then as we get the patient to come in, they get their echo, our physician then reads the echocardiogram, writes out the report, then the pharmacist will then read the report and then kind of work on an assessment of whether or not it needs to hold the medication based off ejection fraction, make dose adjustments, et cetera. And then we go into just submitting that patient status form on the REMS program after we call the patient, assess for any symptoms, side effects, how they're doing with the progress on the mavacamten, ask for new drug interactions, all of that. Then we submit the prescription accordingly. And we kind of rinse and repeat for 8 and week 12. But once we get to week 12, we can make that dose adjustment that I talked about. But then if we're on a stable therapy where their gradient is less than 30, then we can continue with just maintenance echoes every 3 months, and then we just kind of go around in circles and around in circles until the end of time.
So some take-home messages. Obviously, obstructive HCM carries a lot of comorbidities, but also lifestyle modifications, and doing something about it is going to be very helpful in a lot of these patients. Current guideline managements reflect underpowered studies, observational studies, all kinds of retrospective stuff, right? So, and first line of therapies are not really that sufficiently effective and poorly tolerated. SRT in the right hands is highly effective and safe, but there ain't too many right hands available. That's the big problem.
And so what we have available to us now are really a new age within the world of hypertrophic cardiomyopathy, are cardiac myosin inhibitors. They're the first disease-modifying therapy for obstructive hypertrophic cardiomyopathy. Mavacamten thus far is the only FDA-approved cardiac myosin inhibitor, with aficamten having just completed SEQUOIA, its phase 3 trial, just recently in the past few months. So real-world experiences we've talked about with mavacamten has been overall quite positive with regards to efficacy, safety, tolerability, with outcomes being quite comparable to what we see in clinical trials. So successful obstructive hypertrophic cardiomyopathy management really depends on implementing just designated workflows in order to manage the medication. It could be a multidisciplinary scenario as well. And really, as always, just remember to incorporate shared decision-making with the patient when it comes down to treatment selection from our plethora of options available.
Thank you very much for joining. And we have more than 10 minutes for Q&A. We can start with some that we have online, but sir.
I got multiple questions, so I'll just try to summarize it a little bit.
Perfect.
The first question really is, you mentioned about high volume centers and negative outcomes typically are in low volume centers. So how would a patient at risk get to a high volume center? And then secondly, given these new agents, are they cardio regenerating, or do they just slow down the disease progression and the patient still has the condition? So eventually, 5-6 years later, the condition comes back.
So I can take that question. So how do patients access high volume centers? So mercifully for this disease, there's multiple patient-facing advocacy groups available in North America and now emerging rest of the world. So, connecting to those kind of organizations, they can direct these patients to the right location based on geography. Google, internet is another way. You have to do your due diligence to understand. So I think, just walking into a random place and expect to get the best treatment is not, it is important to recognize that that's a bad strategy. And what was the second question? So yes, look, we don't have long-term data for these drugs, right? So we need long-term data, but based on both EXPLORER trial and the VALOR trial, including the long-term extension arms, we have seen using cardiac myosin inhibitors, there's mass regression, there's left atrial volume index regression, there's improvement in diastolic dysfunction, there's also stabilization of myocardial fibrosis. So all these things point towards favorable remodeling. So if we follow these patients for a relatively long time, my expectation is that the downstream positive ramifications of these favorable remodeling scenarios will play out. Again, look, we know for years a successful myectomy relieves obstruction, and these patients have a age-gender matched normal survival compared to a normal population. So we know that relieving obstruction in itself is a very good thing. So time will tell. We cannot put the cart before the horse. So there's an important question. There's a series of 2-3 questions that are summarized. We will merge them together. One is related to how to identify outflow tract obstruction. And outflow tract obstruction can be dynamic. Yes. So that's why one of the things that has emerged importantly is we have recognized that we need to elevate our game as echocardiographers and imagers. There was a substantial amount of heterogeneity in how people were measuring, how the reports were generated, and even in the same location, people were not being diligent. So ASC, American Society of Echocardiography, ACCH, everybody's recognized this, and we have come out with guideline documents of a Cliff's Note version of this is how you do an echo in an HCM patient, and these are the bare minimum things. So hopefully with increased education, these things will get better. I have a question for you. As a practicing pharmacist, how do you think, what are the things that this fine crowd can help you with in terms of simplifying the process of dispensing CMIs or any of these drugs like these, like prior authorizations and all the never-ending song and dance about phone calls and rejections and appeal letters and all that?
Yeah, I think maybe consistency with regards to criteria. I mean, every payer has a different idea of what needs to happen, but it might be a potential difference in education of what is the actual field of hypertrophic cardiomyopathy looking like. So with regards to kind of our workflow that I talked about, I hinted at a tiny bit, was we try to train each other to know everything about all the options and justify why we're selecting a cardiac myosin inhibitor in the beginning. That's a part of the initiation note that we write, and then we say you have to submit this with the prior authorization to smooth things out. When we first started doing this, we'd get a lot of back and forth phone calls, lost fax sheets and everything. But we found that as we just justify everything out at the beginning, why we're not choosing beta blocker or why we can't go up on beta blocker, maybe their heart rate's too low, maybe they have intolerances to these medications, we put that in the script and then we submit it accordingly. Sometimes we still get a little bit of pushback every once in a while. Again, sometimes I have to do a back and forth appeal to justify further, but I think there's inconsistency with regards to payers in their idea of what should and shouldn't be a criteria for this medication class. That's probably the most difficult part of the whole series of getting this medication started.
So There is a question, I think, along the lines, is it reasonable to require a trial of disopyramide prior to coverage of mavacamten? I'll take that question.
And I'll comment right after.
The answer is no.
Yeah, it's not.
Absolutely no. Disopyramide was never tested in a prospective trial. It's an antiarrhythmic drug that was then packaged because of its negative inotropy effects. Okay? It has a lot of anticholinergic-like side effects. Okay? I've used this term before, I'm going to do it again. It's kind of like a mother-in-law. It takes a while to get used to. Even then, you may or may not get used to. Okay? So today, in light of the overwhelming randomized controlled trial data, at least in our practice, it's the first-line beta blocker calcium blockers. If that doesn't work, uptitrate doesn't work, the mavacamten. At least in our site and other large programs, our practice was about 5% disopyramide, if that. And I'm talking really large centers. And that number has gone significantly lower since the drug approval. And, we have surgery to offer before I think about disopyramide. There's another couple of webcasts. What do you think?
Can I just comment real quick, too? For disopyramide, it's always important to think about some practical considerations. Multiple times a day dosing, 2 times, 3 times, even 4 times is how much you got to take that medication. And what Dr. Desai was talking about, too, with regards to those anticholinergic side effects, they happen at every dose. You don't have to be at a higher dose. You can be at baseline dose, even just like 150 twice a day. Or even I had a patient take an instant release 100 twice a day, which is kind of funky, but still has anticholinergic side effects even from the lowest possible dose, which can be quite limiting and obnoxious.
There's one person has sent these questions, and I'll address it. One is, how effective CMIs are going to be in non-obstructive HCM? Time will tell. ODYSSEY and ACACIA are answering that question, and we should have at least some early data by this time or a little later next year. ODYSSEY is officially in follow-up. How about HFpEF? Again, same way, there's talk about migrating these drugs and testing in a broader HFpEF population. We don't know the answer to that. Could you comment on Imbria's drug, Tenaya's gene therapy, and Edgewise 7500? So full disclosure, the only patients in the world that have gene therapy from Tenaya are my patients, so I will not talk about that. The data is still pending. Edgewise is, again, I'm on there. Yeah, this is, the trials are still starting, so way too early. And Imbria, what was presented at ACC a couple of weeks ago, this is a novel mechanism. It is manipulating the fatty acid metabolism, and in a phase 2 trial of 60-something patients that was published simultaneously in JACC, it showed that in a small subgroup of patients with KCCQ less than 80 and higher NYHA class, there was an improvement with the Imbria drug versus placebo. In the overall population, of course, the numbers were small. The p-values were non-significant. So this is still in early phase 2 development, so time will tell. But the fundamental, most important thing is what? 5-6 years ago, all we had was all this retrospective data. Now we cannot spend another day without seeing a new trial being announced or a new company popping up testing something in HCM. So I think the future is truly bright. Do we want to talk about the ICER report? Yeah, let's do that. So there is something about ICER. I'm going to ask you that question. So the ICER report on mavacamten used NYHA classification to measure patient functional status. Would it have been better to use a PRO like KCCQ? And so what are your thoughts?
Simple question, simple answer, yes. So ICER 2021, right around just before mavacamten got FDA approved, looking into cost-effective analysis, everything like that with regards to this medicine. So their efficacy point was really achievement of NYHA class 1 symptoms, so asymptomatic. So the reason why they chose that is when they compared conventional therapy, beta blockers, calcium channel blockers, disopyramide, and even septal reduction therapies, the only common endpoint that was across all of these studies, again, remember this is mavacamten had randomized controlled placebo trial, while disopyramide is based off of, they looked at specifically a registry analysis, and then, so not the most robust data from there, but the only endpoint that was common among all of these studies was NYHA class. But the problem with NYHA class, while it can be very easy to do, you just kind of look at your patient and ask them specific questions to quantify or qualify exactly where they are with their symptoms. There's probably about a 50% intervariability rate between observers. You'll have one cardiologist say, I'll ask all these questions and say, you're NYHA class 2. 50% chance next person comes in and says, you're NYHA class 1. So right there, that variability kind of makes you question that outcome of utilizing that in the ICER report. I always still try to give a little benefit of the doubt because that was all that was available among all of these studies. Those studies didn't look at KCCQ, which is much more robust in terms of an outcome, in terms of looking at quality of life. You could also look at like cardiopulmonary exercise testing, which we have in cardiac myosin inhibitors. Great test. Tells you exactly how much peak oxygen consumption they're going through, and it correlates well with outcomes. But mavacamten is really the only one that has the most robust data with regards to measuring that kind of outcome.
So, and I'm going to add that the ICER report was generated way ahead of its time. Basically, we had no data, no nothing. A lot of it was coulda, woulda, shoulda. So I think, now that we have real world evidence, I think this is perhaps a time for ICER 2.0. So anyway, a couple of comments, another question. The guidelines or that I assume people are talking about the REMS recommendation, conservative with respect to monitoring via echoes, meaning we are doing too many echoes. And what would it take to change so that we can reduce the burden, not just healthcare costs, but the inconvenience to the patients? Again, this is not a problem that we are going to solve in this room, but the FDA is looking at this data, or should be looking at this data. There was an abstract presented out of the REMS database at the last ACC. The manuscript is currently being reviewed, so it should be in peer-reviewed domain hopefully soon. And it's data like that from the REMS program, plus these real-world experiences that are going to guide what the recommendations are. And, time will tell. Time will tell. One other question, do you stop the beta blocker when you start mavacamten due to better benefits? So technically, at this point of time, in follow-up, if the patients are starting to do better, then we try to taper down some of their background therapies because of potential side effects. But there's the ongoing MAPLE study, which is comparing head-to-head aficamten versus beta blocker. We'll see what the results show, and perhaps that can take the conversation upstream, and could you contemplate using CMIs as first-line agents in certain selected scenarios? We don't know that yet, so that's why we wait for the trial. I think we are done.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/DMR860. This activity is supported through an educational grant from Bristol Myers Squibb.